and the house filled for such an important conversation. This is just one of the many, many reasons why I love my job. Good evening and welcome to the JCC Manhattan. My name is Dava Shub, and I have the pleasure of serving as the JCC's Chief Programming Officer. On behalf of the Marty Ann Meyerson Center for Health and Wellness, it is my privilege to welcome you to tonight's program, looking at the growing health concern in the Jewish community, hereditary cancer risk, and the relevance of population screening for the BRCA gene. Whether it's your mother, sister, friend, colleague, or your own personal story that motivated you here tonight, ovarian and breast cancer has left few of us untouched, and we are very glad that you're here. Tonight we will welcome to our stage the Pulitzer Prize-winning journalist Amy Harmon. Amy is a reporter for the New York Times covering the impact of science and technology on American life. She won a Pulitzer in 2008 for her series of stories, The DNA Age, one of which chronicled a young woman's medical life decisions after learning that she was a BRCA carrier. Her Target Cancer series received the 2011 National Academies of Science Award for Print Journalism, and her 2012 article about a young man with autism won the Casey Medal for meritorious reporting. She is also a recipient of the Guggenheim Fellowship in Science Writing. Amy lives here in New York City with her husband and their 10-year-old daughter. Amy will be in conversation here with three distinguished physicians who dedicate their professional lives to this complex topic. Dr. Susan Domchek from Penn Medicine, Dr. Susan Klugman from Montefiore Medical Center, and Rabbi Dr. Edward Reichman, also from Montefiore. We'd like to thank the Basser Research Center for BRCA at Penn Medicine, as well as the Program for Jewish Genetic Health at Albert Einstein College of Medicine of Yeshiva University for partnering with us tonight. This program is also made possible in part by the generous support of our Friends of Performance series with Allison Charney, who's here with us this evening. I'd also like to extend a special thank you to our outstanding JCC team, specifically to Melissa Donald Donovan, who imagined tonight's program and made it happen from start to finish. This is not a one-sided conversation where you simply sit here in your seats and hear what the experts have to say. We encourage you to participate this evening by jotting down a question or two on the index cards you'll be provided, and we'll be collecting the cards a little later so that our panel can address some of your questions towards the end of the program. Amazing things happen in this space when you, our community, have the chance to engage on a deep and personal level around the topics that matter most in your life. Whether this is your first time at the JCC, we welcome you. If you've been here a million times, we welcome you back. And for those of you who enjoy this kind of really interesting, high-level intellectual conversation, keep an eye for future programs coming. There'll be more things that I think you'll catch your eye and attention. After the program, please join us in the lobby for a coffee and dessert reception and continue the conversation. But now, without further ado, I ask you to silence your cell phones and welcome Amy Harmon and her distinguished guests to our stage.
So much, can you hear me? Yes, for that very nice introduction. Our topic tonight is, I really love the title of it. It's Testing for Cancer Risk in the Jewish Population, a Community Conversation. And to me, the conversation part is so important because, as David mentioned, I wrote a story in 2007 that was the story that got the most response of any story that I've ever written for the New York Times, and I've written a lot of stories. And it was about a young woman who's 33. She tested positive for the BRCA1 gene, and it was about her decision to about what to do about that information that she got. And I followed her, and she was a medical resident. She was highly informed. She knew everything there was to know about this, but she still really agonized over what to do about it. And I followed her and through her decision to get a prophylactic mastectomy. But what I think really resonated and why it got so many letters, and I still hear about it from people, is because it was because of her mother, who was a character in the story, who at one point said to her daughter, she had passed the gene on to her daughter, and she said to her daughter, it's so hard, it's so hard for you. I kind of wish this test didn't even exist because you wouldn't have to be going through this. She was worried that, you know, her daughter wasn't married. She had a boyfriend, but they weren't married. She was worried that if she removed her breast, she wouldn't be able to get a husband, and she wouldn't be able to nurse her child. And she said, oh, you know, I just wish you didn't have to know. And to her mother, Deb said, well, but I have this amazing gift of knowing my risk. And by the end of the story, the mother kind of came around to understanding it that way. But I think that the mother, even though this is a story about Deb, the mother's story really resonated with people because it's such an understandable instinct to want to just kind of cover our eyes and our ears and just say, like, we don't need to know this, you know, our life was easier the other way. And I think that there's a lot of confusion and fear still around this test, and that's why it's so important to have this kind of conversation, and that's why I'm so happy to be here with this, because there's very few people in the world that could have a better conversation than our distinguished panel. And with that, I'm going to introduce them. I have to my immediate left Susan Domchek, who is, I'm going to take off my glasses who is the Bassler Professor of Medicine at the University of Pennsylvania and the Executive Director of the Bassler Research Center for BRCA and the Director of the Marion and Robert McDonald Cancer Risk Evaluation Center at the Abramson Cancer Center and a Senior Fellow at the Leonard Davies School of Health Economics. In the middle, we have another Susan there on the end, but in the middle we have Rabbi Edward Reichman, who is a professor of emergency medicine and professor in the Division of Education and Bioethics at the Albert Einstein College of Medicine at Yeshiva University, where he teaches Jewish medical ethics. Susan Klugman is the medical director for the Program for Jewish Genetic Health of Yeshiva University, Albert Einstein College of Medicine. She has served as the director of the Division of Reproductive Genetics at Einstein and Montefiore Medical Center since 2008. So welcome, and we will now start our conversation. And I'm just going to start off by asking each of you to talk a little bit about your relationship to BRCA in your sort of everyday professional lives. What do you do? Tell us about how you interact with people who are testing for this gene.
So our panel today has a few different points of view. So I'm a medical oncologist, so in my day-to-day life I see women and men who have breast and ovarian cancer, largely focused on individuals who have genetic risk of these diseases. I also run our genetics clinic, though, so we see individuals before and after genetic testing and follow individuals who have genetic risk. And in my other part of my life, I do a lot of research in this field, both to come up with new drugs and new preventative options for individuals dealing with this risk.
Ed?
Well, I am a clinician as well. My role on this panel is really not that of a clinician. I'm here as an educator. I teach Jewish medical ethics at Albert Einstein College of Medicine in the broader Jewish community, and at the Rabbinic School of Yeshiva University. So I engage the people who are testing for these conditions and need to know what to do and what the Jewish religion has to say about this testing.
Hi. I'm a clinical geneticist in a department of OBGYN. I'm also an obstetrician gynecologist, and I practiced as such for about 10 years before transferring over to clinical genetics. So in our division, we see patients who are prenatal patients, and we also see patients who either have cancer or are at risk for hereditary cancer syndromes. And that generally involves, a lot of times that involves breast cancer, because breast cancer is one of the most common cancers that we see in women.
Thanks. I forgot to mention that we are going to have we said it was going to be a conversation, and we are going to have a conversation here, and then we're going to have a question and answer session. There are cards going around in the audience, so you can write down, we'll have microphones, but you can also write down questions that we can read later. So Susan D., can you just teach the audience a little bit about BRCA and what are the risks that are associated with BRCA genes?
Sure, and everyone should have a handout that they received on the way in. This is in lieu of slides because we find that people get glossy-eyed when we put up slides. But BRCA1 and 2, first of all, are genes that everyone has, and that's an important thing to know, and that these genes make proteins that help the cells repair DNA damage. It's when you inherit a bad copy of one of those genes, so a mutation in one of those genes, where the protein then doesn't work, that's when you have an increased risk of developing breast or ovarian cancer. It's also really important to know that most people who have breast cancer do not have BRCA1 and 2 mutations. That's actually true even in the Jewish population. About 10%, if you take all comers who are Jewish descent, who have breast cancer, about 10% have a mutation. That number's higher if you're younger or if you have a family history. All those things we'll get into later. But BRCA1 and 2, again, are much more common in the Jewish population. The risks associated with these mutations are largely breast and ovarian cancer. And in the second figure, you see that graphically represented, where the little blue bar has sort of the average risk in the general population, and the purple bar is the risk of having a BRCA1 and 2 mutation. Also, as we'll talk about later, there are ranges of risks. So these are the highest risks we report, but there are ranges of risk, and that's actually a subtlety that we'll get to when we talk about kind of testing everybody. But as you see, the risks are much higher. So if you know you have one of these mutations in BRCA1 or 2, we do know that the risks are much higher. The important thing to realize is that an individual who has a BRCA1 or 2 mutation, 50% of the time she gets that from, or he gets that from their father. And that's one thing that we find is extremely underappreciated. Most people think that the only family history that's important is from their mother's side. It's just not true. And we have people also say, well, I told my doctor and they said not to worry about it because it was from my dad's side. And so that they should have failed medical school. That's wrong. So your dad's side of the family really does matter. And in figure 3, this is how we keep track of things in the genetics clinic, where circles are women and squares are men. And you can see here that there are 2 sisters with breast cancer, but their paternal grandmother is the one that had ovarian cancer. That's a very significant family history that matters a great deal, and it's something that's really under-acknowledged. So for my portion, there are genes, a mutation in which increases your risk, and your family history matters.
Thank you. Susan Klugman, I think a lot of what people want to know is, should I get tested? Who should be tested? Can you tell us what are the current recommendations for who should be tested, and what are some of the reactions? What data do you have about how people respond to getting the information once they have it?
So I'll start first with a little bit of history. So for the BRCA genes were discovered in the mid-90s. So we've actually been doing testing for almost 20 years now. And the guidelines have really morphed in the last 20 years. And insurance companies are actually more accepting of testing. So there are current guidelines from many, many different national bodies. But I'm assuming that Dr. Domchek's group also uses the same guidelines. We generally go from the for NCCN guidelines, it's National Comprehensive Cancer Network, and those guidelines come out on a yearly basis. So in general, and realize different insurance companies tweak this different ways. In general, if you are not Ashkenazi Jewish, we'll get to that afterwards, but if you're not Ashkenazi Jewish and you have breast cancer and you have a strong family history of either breast cancer, ovarian cancer, believe it or not, pancreatic cancer, and some other cancers, in general, you would be covered. Now, why are we talking about coverage? These full sequencing for the BRCA 1 and 2 genes cost somewhere in the high $3,000s to almost $4,000. In the Ashkenazi Jewish population, we first test for 3 founder mutations. Now, is it okay that you were going to get to we're going to get to that in a second. It's on the back of your handout. So I'll let Susan Domchek get to that. So because this sequencing is so expensive, that's why there's been so many guidelines for this. You asked if it's how people react.
Yes.
So I strongly believe in what we call pre-test counseling. So in our clinic, and I know at Penn and all the other major medical centers, a patient will see a genetic counselor probably for a good 35 to 45 minutes, go through an entire pedigree, similar to what you have in Figure 3, but obviously more extensive, discuss the type of cancers that each family member developed, discuss the age of diagnosis, which is also key, because when we see cancers at younger ages, we think more of a hereditary cancer syndrome or a BRCA risk. And after that, and during that counseling, they also discuss insurance implications. So the patient is prepared. I have to tell you, there are many patients that say, this is too much for me to handle right now, I'm too young, I can't handle it, and they come back.
And they
And
don't
some-
get tested.
They don't
just
get
decide
tested.
not to
Some
get tested.
some find it too scary. And there are women that don't care about anything but getting their test and knowing. And we can give them an idea of the percentage just by family history. Obviously, if your mother or father is a BRCA mutation carrier, or a sister or brother that's a first-degree relative, you have a 50% chance. So in that case, we can give a 50% risk. But we can give an idea if there's a second cousin who has a mutation carrier. We can give percentages sometimes.
Okay. Eddie, I want to ask you. People, I think most of us are in agreement that if you have a high risk of having a BRCA mutation, you could get a lot from getting this test if you're ready for it. But so, is there anything in Jewish law that guides people to or away from getting the information?
Excellent question. I have a brief confession to make. I actually came here to listen to the two Susans, but I couldn't get a spot because it was closed out, so I asked if I could speak. But honestly, because this is a gene identified with the Jewish community, it behooves us as Jews to understand the historical context and what our ancient tradition has to say about this. We will talk about specifically the breast cancer gene, but of course it needs to be taken in the context, much greater, broader context of the Jewish tradition in general, which is thousands of years old. Jewish tradition has a wealth to say about every aspect and every dimension of medicine from literally before life till after death. And this is but one small piece of that greater puzzle. So indeed, it is a very important aspect of the Jewish tradition to maintain your health. Maintaining your health is essential. Maintaining your health is important to be a practicing Jew, to serve God. And as such, every aspect of preventative medicine is not only okay to do, it's obligatory to do. And that's another essential aspect of our discussion, as opposed to a general secular ethical discussion where things are discussed in terms of the rights of the patient. That term is really not invoked in a Jewish discussion. Judaism is a law. It's an ancient legal tradition. Therefore, things are discussed in terms of mitzvot, in terms of obligations and prohibitions. So we need to analyze all the issues that relate to this gene from that perspective. And it clearly falls into the category of preserving your health, and we need to listen to the two Susans in terms of how exactly we would apply that.
Thank you. Okay, so Susan Domchek, how do we know that BRCA mutations are common in Ashkenazi Jews, and why are they common? And if that's really true, if you can explain that, why is that the case?
Sure. So as Susan Klugman said, the BRCA1 and BRCA2 were identified in the 90s, cloned in 1994 and 1995. And really, very soon after that, there was a recognition that there are specific mutations in these genes that were much more common in individuals of Ashkenazi Jewish descent. And to start there very quickly, the analogy we give is that if BRCA1 and 2 are like a very large book where you're looking for a spelling error, we know that on 3 specific pages, there are misspelled words that are common and recurrent in people who are of Jewish descent. We call these founder mutations. And there were a number of studies that were done in various populations, Mary Claire King in a New York breast cancer study, in Israeli studies, in a Washington study. Many different populations were studied of Ashkenazi Jewish individuals. And the summary is that 1 in every 40 individuals of Jewish descent has one of these founder mutations in BRCA1 or 2. So when you think about that, that's a lot, 1 in 40, 2.5%. So it's actually quite common. And because it's both common and because it's one of 3 specific pages, it also brings the cost of the testing down very significantly from that $3,000 to $4,000 mark to it can be as cheap as $300, but in the $300 to $500 range. So it makes the testing much more straightforward because there's a lot, it's much more commonly found. This testing is much more straightforward, cheaper, and there's less uncertainty. There's nothing that we call a variant of unknown significance in these tests. So it really sort of changes the dynamic. Now, why is it more common? I'm sorry, going on a little bit, but in figure 5, this gives sort of a schematic of what we think about when we think about founder mutations. So the idea is, if you look to your left, if you can see in the light, all the little squares are individual people. And one of the squares has a little red mark on it. And that's an individual who has a BRCA mutation. At different points of time along the way, a population undergoes stress where a number of people die off. And I can't imagine that you guys can think of things that have happened like that in the Jewish population. So there have been a number of different periods where there's been a great deal of stress. And what happened in this case, randomly, is that some of the people who had the mutation survived, a lot of the other people died. And when that population then expands, the mutation is sort of overrepresented in the population. So this is how we think about this. And so that's one of the sort of theories for why this is more common. There are other populations where there are founder mutations, by the way, but in the Jewish ancestry is one of the most common ones. So that's how we think about it.
Okay, thank you. All right, so it's common. It's very common. 1 in 40. That's a number that we should remember, right? So Susan Klugman, some people talk about, and actually a colleague of mine at the Times has really written very eloquently about this recently, Ronnie Rabin, that this idea that since it's so common, that the test should be offered to everyone of Ashkenazi Jewish descent, not just, as you were saying, you do, when people come in and do counseling, you do a whole pedigree, you say, well, you're more likely to be at risk, so we're going to offer you this test because of your family background. So what can you talk a little bit about the discussion that's happening now around whether that should be broadened, that category?
So I mentioned the categories for testing from the NCCN guidelines, and the last category is Ashkenazi Jewish. So there is a lot of thought to say that just being Ashkenazi Jewish puts you in a high-risk category. But to date, the guidelines are having breast cancer and being Ashkenazi Jewish. You don't really necessarily have to have a strong family history, or being Ashkenazi Jewish and having a strong family history. Just to give a little bit of history again, the reason that we are doing this testing is that we do these tests to kind of follow up from your last question, and then I'll answer this question. The results are empowering because women can do something. We do know, and I skipped figure 4. You may have to flip over again, that we do have increased screening and increased surveillance with mammograms and breast MRIs for BRCA carriers. We do know that there are medications and there are surgeries that are life-saving for these women. So while the results may be scary, they are empowered with the information and can act on the information. So now to Ronnie Rabin's article, she referenced a study in Israel that's been going on for almost a decade where Dr. Efrat Levy-Lahad tested 7,000 men randomly, men with and without family history of breast cancer, ovarian cancer, pancreatic cancer. And what she found was those men who were positive, and then she did test their siblings, their siblings did not necessarily have to have had a family history to develop cancer. Let me rephrase that. These families were considered high risk and developed cancer with a BRCA mutation I'm not saying this right, I apologize. There are families with a BRCA mutation that did not have a family history and those that did have a family history. So the BRCA families that did not have a family history that might not have been tested with our old paradigms developed cancer at the exact same rate as those who did have a family history.
Okay,
Am I
so
clearer? I apologize.
Yeah, so that was a surprising and unexpected
Surprising
result, right?
and significant. Now, there are a lot of things and a lot of issues and a lot of things that we can discuss about the study. And Dr. Domchek and I were discussing it prior, but it is really a significant finding.
So that obviously speaks to the idea that everyone should be tested. It's not necessarily about if your mother had breast cancer or your paternal grandmother, as we learned. We have to think about that as well. But it could be anybody. But so can you talk? Well, you were talking about this earlier when we were in the agreement. But I want to hear this discussion about that it almost sounds like, oh, that's obvious. Everyone should be tested. But what there are pros and cons, right? So what are some of the pros and what are some of the cons? And you can jump in here.
You know, we can talk about this all day. So we'll try to trade off. You know,
Keep
the
track of
pros
the
are
time.
obviously, exactly, we all have 2 minutes. You know, the pros are, as you heard, if you identify that you're at risk, you can make medical decisions and you can decrease your risk. But, you know, those decisions we have are kind of not so great. Like it's removing ovaries when you're 40 and it's removing your breasts and things like that. And so what are the risks? And I think some of the challenges are in that study, despite the fact that it was large, they still identified, you know, like 160 families in the end that had BRCA1 and 2 mutations. So by the time you dug down into it, you know, who had no family history or who just had no family. So let me rephrase that again. It's very different if you have, you know, 6 aunts on each side of your family and no one has cancer. That's different than having no aunts, because that might sound like a funny statement, but you can't tell if there's risk of cancer if there were no women to develop it. So the structure of a family history actually matters a great deal and has to be kept in some account. The other issue, which is sort of complicated, is that when you look at that figure 2 of that really high risk, actually some studies show that the risk of breast cancer could be as low as 35%. So how do we talk about that? Who has a 35% chance of developing breast cancer? Who has a 70% chance of developing breast cancer? Who needs a mastectomy? Who doesn't? These are major things. And then my final point, because I go on all day, is that we also have to weigh to figure out how to do this. So in a real implementation way of how do you identify people who are Jewish, offer them testing, go through with them the pros and cons so that they can make the decision in sort of an efficient manner. And I think that it's something that's really important and we have to figure out. And I think Susan could probably talk a little bit about, you know, Tay-Sachs. This got done, but Tay-Sachs is a different disease, an autosomal recessive. You need 2 bad copies, not just 1. So there's some different issues. So we'll play off each other because I think there's a lot of things
maybe
to discuss.
so maybe everybody knows what Tay-Sachs is, but maybe they don't. So maybe can you just sort of explain what she's talking about with autosomal, 2 copies, all of that stuff?
So we've been doing Tay-Sachs screening in the Jewish population since the early 70s. And Tay-Sachs, and there are in some centers 18 and even up to 36 what we call autosomal recessive disorders that have mutations in the Ashkenazi Jewish population. So Tay-Sachs, for a child to develop Tay-Sachs, both parents need to be carriers and both parents need to pass that mutated gene onto the child. So that means if both parents are carriers, 25% chance that the child would be affected. It's very different with BRCA because BRCA, you only need 1 parent and 50% chance of passing that on.
That's because each parent passes on 1 copy of each gene. So, right? So
Exactly.
That's how you're getting the 25%.
99.99% of the time. So bottom line is that if you're a Tay-Sachs carrier, you don't know. You know, and it's actually the number is probably about 1 in 25. Of Ashkenazi Jews are Tay-Sachs carriers.
So when do you get tested for that?
So in general, most people are tested when they're pregnant, but we're moving towards trying to test pre-pregnancy. And this will lead into BRCA. If we test pre-pregnancy and we identify a couple that is what we call a carrier couple, meaning the husband and wife are both carriers and they do not want to have a child with Tay-Sachs. Of course, you can have testing for Tay-Sachs during the pregnancy with a CVS or an amniocentesis early on in the pregnancy. But there's at the time of in vitro fertilization, a cell develops to an 8-cell embryo by day 3, and microscopically, super microscopically, you can extract out one of those cells and test that one of those cells for Tay-Sachs.
So you're saying that even if you have a man and a woman, both carriers, they have a 1 in 4 chance of having a baby that has Tay-Sachs, they can use this procedure.
So they
you're
can use in
talking
vitro
about.
fertilization with something called pre-implantation genetic diagnosis.
Okay.
And actually, most recently, that has been used for BRCA as well. So the uptake is not as high as the autosomal recessive Ashkenazi Jewish disorders, but there are families out there that are testing embryos at the time of in vitro before implanting them for BRCA.
Okay. So how does this relate to? So I think Susan made sort of a case for what some of the downsides of offering a BRCA test to just everybody who has Ashkenazi Jewish background. But how is the Tay-Sachs model? How might that apply to? I mean, does that sort of hold a lesson for us in terms of what might be useful or good about broadening the test?
So population screening started in the 70s, and I would say it took a couple decades to perfect. And there are still issues. Fortunately, there are very, very few Tay-Sachs babies being born now. But as far as BRCA and moving towards population screening, it's a little bit different because it's an autosomal dominant disorder. So the actual patient, not necessarily the fetus, could be affected.
Right. Just to say it just a slightly different way, if you're a Tay-Sachs carrier, you don't have Tay-Sachs. So it's like a risk.
You don't even know it. You could be walking around.
Right, you're totally fine. You don't have any risk. So you're preventing having a baby with Tay-Sachs. So on the one hand, we know that the Jewish population can take up genetic testing and on a population basis because it happened in Tay-Sachs screening. But on the other side, you've got this gene mutation where the person who has it has the risk. And then you have a 50% chance of that gene because you pass that, you have a 50-50 chance of having that gene mutation be passed along to the children. So it just has issues for the family. That's not supposed to be scary. I mean, I definitely view BRCA 1 and 2 testing as empowering for the reasons that have been discussed. And the story, Amy, that you told is so telling, which is a lot of the young women who get testing feel like, I am now in charge of, if you will, my destiny, and I can prevent cancers that are occurring, and I won't be taken off guard, and it's mine to choose and mine to have. So there is that empowerment, but we also at the same time need to be careful to do it in the right way so people make informed decisions, because that's really all this is about, is people having information to make the best decisions for them. For some people that'll be to test, for some people that won't be to test. But then how do we actually do that in practice is sometimes challenging when we start talking about population-based screening, because that's a lot of people to screen, and how do we do that efficiently?
I want to ask you more about that, but I want to ask first, Eddie, what does the Jewish law have to say about this particular question? Is there anything about, not, let's say I don't have a family history, but I am of Ashkenazi Jewish descent. Is there any guideline for that situation?
There are many issues, actually, that relate to Jewish law and genetic testing. And let me go back historically to the Tay-Sachs issue, which started a number of decades ago. The first gene that was testable in a carrier, the first gene that was testable, correct me if I'm wrong, in utero as well, and happened to have been associated with the Ashkenazi Jewish community as well. So at that stage, the very first question that was asked was, should anyone even be testing for this? So Susan just said that it's empowering to test because in a certain way you can control your destiny. So does that apply theologically? So the very first question that was asked when this gene came on the horizon and it was testable was, should a Jew be testing for this? Is it something appropriate to do? Because maybe we should put our belief in God. If God deigned that we should have this gene, we should pass it on. Perhaps we are intervening in ways inappropriate in the workings of the world, and leave that to God.
And we should say, sorry, just to interrupt, in case what Tay-Sachs actually is, how it manifests. Can you just sort of just describe one of you?
I'm happy to.
Just
leave it to the geneticists.
Yeah.
So it is a disease which primarily a neurological disease, which manifests very early in life. Tragically, the child usually develops relatively normally until roughly 3-4 years of age, and then there's a regression of neurological milestones, and it's associated with close to 100% mortality based on the exact type of Tay-Sachs that an individual has. It was identified in the 1880s by a number of different people, including Dr. Warren, Warren Tay, rather, who was an ophthalmologist, and Dr. Bernard Sachs, who was a neurologist, hence the name Tay-Sachs, hyphenated, for two physicians who identify different features of that disease. To return to the disease, to the theological discussion. So one of the greatest sages of the late 20th century was Rabbi Moshe Feinstein, who was asked this question, and his response was that it is one cannot apply that theological stance to this issue if it is testable, and one can prevent the birth of a child that would be obviously disastrous for the child and for the family, then one is indeed permitted, if not obligated, to do so. But then a whole host of other issues evolved. So if you're allowed to test now, and the testing, by the way, in the Jewish community was earlier, was premaritally. So the testing was instituted. There's an organization which some of you may be familiar with called Dor Yesharim, which was started by a man named Rabbi Eckstein, who lost 4 children to Tay-Sachs disease. And at the time, historically, when Tay-Sachs gene was testable, and he decided he's going to change things and not have people suffer the tragedies that he suffered, and he developed an organization whereby people would test before they dated to determine if they were carriers, and if they were found to both be carriers, then he would recommend that they not continue dating. And we're not going to discuss the details of the infrastructure. It is fascinating. But then the question arose, if people were already married or didn't test before, could they perform amniocentesis to be able to determine that the fetus was afflicted with Tay-Sachs? And if the fetus was found to be afflicted with Tay-Sachs, could an abortion be performed? And this is obviously a very difficult religious question, and abortion is discussed extensively in Jewish law. There is not one opinion. There are divergent opinions. Just to share with you the polar extremes related specifically to Tay-Sachs, Rabbi Moshe Feinstein was of the opinion that it was prohibited to perform an abortion in this scenario for any fetal indication, and therefore he did not allow amniocentesis to be performed. On the other polar extreme, there is a prominent rabbi in Israel named Rabbi Waldenberg, also passed away a number of years ago, who not only allowed the amniocentesis, but allowed abortion up to the 7th month of gestation. So that's the polar extremes within the Jewish community. And then moving into the 21st century, Tay-Sachs fortunately is very uncommon by virtue of the testing. That's why it's uncommon. That's why nobody sees it. If we would have had this conversation 40 years ago, we would have all raised our hands if we would have asked if we've seen a case of Tay-Sachs disease, but today very few of us have. But now you can perform a PGD, or pre-implantation genetic diagnosis, if a couple are both carriers, and determine whether the embryo that they have, that a couple has, they can fertilize the embryos in the laboratory and identify which embryo has Tay-Sachs and which doesn't. And then you can implant the ones that don't have Tay-Sachs. So the question from a Jewish perspective, is it permitted to undergo that procedure? Is that also playing God to a certain extent? And it's a very complex issue. It involves this harvesting of the sperm, harvesting of the egg, all of which have legal issues associated with them. And it involves disposal of the extraneous embryos, and very briefly, Jewish law does not consider the embryo ex utero or in vitro to have the status of human life like other religions do. So those issues were all discussed in the last 40 years with Tay-Sachs, and we are trying to learn from those issues in terms of applying to BRCA in terms of testing. Now, just very briefly, the issues that relate to BRCA are different. So if one is found to be positive for BRCA, obviously there are surveillance issues. You can take medications, you can do surveillance with mammograms and MRIs and other imaging studies and ultrasound, or you could do surgery. Now, doing elective surgeries in Jewish law is an issue, because generally you shouldn't undergo risky procedures for no reason. But you can do it for the sake of saving your life. So we rely on the scientists, like those sitting to my right and left, to help us make that decision whether it should be allowed to do or even perhaps obligatory to do. Although one could not envision obligating an individual to undergo a bilateral mastectomy. But for ovarian cancer, it becomes much more complicated. Because if someone has a risk for ovarian cancer is associated with fertility. And obviously, if you remove the ovaries, you can't have children. And the very first mitzvah of the Torah is be fruitful and multiply. So how are you going to navigate that? in a woman who's found to be positive for BRCA2 with a high association of ovarian cancer, are you going to recommend that she remove the ovaries now? Are you going to wait till she has a child or 2 children, or fulfills the mitzvah of be fruitful and multiply, which is to have a boy and a girl, and then remove the ovaries? It's not a simple matter. So there is much to discuss.
I actually want to make sure I understand that. So is there a conflict then between Jewish recommendations? Susan Posen, can you say what are the recommendations for someone when you do test positive for BRCA1 or 2? There are recommendations.
So we have a
for
long
what-
discussion. It depends on how old the patient is, and it also depends on if the patient wants to continue to have children, where they are in their lives. But we do know that a prophylactic oophorectomy decreases your risk of ovarian cancer by probably somewhere in the order of 95 to 97%, and in addition decreases your chance of breast cancer by 50%.
But so is Jewish law
have
going
to
to tell
be
me not to do
performed.
that? Is
But
Jewish
the
law going to
question
say I
is-
shouldn't reduce my
No, that's an
risk by that much?
excellent question. So the question is, when is it effective? At
Right.
what age? And that's
So
important.
there are some conflicting studies, but most of the most recent studies say in the order of 35 to 40. And we have to weigh the risks and the benefits of what medical side effects you might have from removing your ovaries. So
I mean,
Susan,
some of the challenges are well stated, which is we know that there's never a zero risk of anything, and so the recommendations just about timing of oophorectomy have to be taken in the context of, if you will, what we call age-specific risk. So to put a finer point on that, BRCA1 mutation carriers by age 40 have about a 3 to 4% chance of developing ovarian cancer by age 40. So on the surface of this, that's not terribly high, but it's much, much higher than the general population. And ovarian cancer also, we really, unlike breast cancer, we can do breast MRI and we're pretty good at screening for it. Ovarian cancer, we really don't have very good screening. Most ovarian cancer, when we find it at a later stage, and later stage ovarian cancer does not have the survival that we want it to have. And thus, we have these recommendations about relatively early oophorectomy, but is 35 the right number? Is 40 the right number? Is 45 the right number? This is all weighing risks and benefits and sort of our estimate, but as we sometimes say in the clinic, the person in front of us, their risk is not 4%, their risk is 0 or 100, right? It will or will not happen to that person. So these are really complicated things about when people feel that they're ready for having a removal of the ovaries, how they feel about additional children, how they feel about menopause, sexuality, issues of other quality of life like bone health, cardiovascular health, and things like that. And then, you add to this, your thoughts about having additional children and when are you done having children anyway these days. So it's very complicated, and that's why when we start talking about population-based screening, you don't want to spring this stuff on people after they test positive. You want to at least let them know that these are going to be, if they test positive, these are going to be conversations that you have to have. So you have to have some degree of understanding going into this test about these complicated issues, or it can be very difficult afterwards.
Just one point of clarification. You said ovarian cancer doesn't have the survival rate that we would like it to have.
Yes.
What is the survival rate? Is it a way to quantify that?
Yeah, I mean, it depends on the stage, but the challenge is that, the most ovarian cancers, unfortunately, are detected at stage, 3 and 4, and, the 5-year survival rates on that can, be as low as 40%, depending on the stage. So these are low survival rates. Now, that's, later stage. We want to detect things at earlier stage ovarian cancer. Patients have much better prognosis than that, but the problem is that we don't have a great way
How much of it is detected at earlier stages right now?
Frankly, you just get lucky, or at the time of
very small
prophylactic
percent.
surgery, you happen to find an early
So
stage
that
ovarian cancer.
40% survival rate really.
I mean, again, that's more stage 4, but it can be that poor, and so that's the problem, is that we really want to do better than that.
and the treatment and the surgery and the chemotherapy for ovarian cancer is really, really difficult. I've taken care of those patients. It is a miserable few years.
Okay, so just returning to the question of whether population-based testing. So, Susan Tomczyk, you were saying, well, part of the complication is we'd have to counsel all these people, and it would be really, just in terms of the logistics of it, it would be difficult. Yet it sounds like, but if the study proves true, the study in Israel, or if it's replicated, or then you're saying that a lot of more people are at risk of this very, these really serious.
Well,
things.
the
So-
one thing I do want to emphasize that it's still true that most, even in this study, a lot of people had a family history. So it's still, the number one thing is not everybody who has a family history gets tested. And if, a take-home message of the night is, if you have a family history,
At
get
least if
tested.
you have a family history.
Go for it. But I think that one of the keys in the field, and Susan can talk about this as well, is that we want to come up with different strategies of how you do effective counseling. Do you really need, do you need a 35-minute counseling session, or is a webinar and an opportunity to ask some questions sufficient? And I mean, I'm not being flippant. We have all sorts of technology now, so maybe the right thing to do is employ technology in different ways to give people the information they need, and do a little less of that direct one-on-one counseling when we're really talking about population screening. Is that the right way to do it? That's one of the big questions, is how to do it efficiently, effectively, and get people the information they need to make an informed decision.
What would be the downside of a webinar? I mean, how often, how often, I guess, how often do you feel like, oh, I really need to be here in person with this woman who is, breaking down in my office, or whatever it,
There is never a patient that leaves one of our sessions and says, I really did not like speaking to a genetic counselor. So they really enjoy that time. They do have some psychotherapy skills, some social work skills, in addition to their genetic counseling training. And they are really masters at what they do. And I do feel that almost every patient has a question. And sometimes that question is very personal. And yes, we can have a webinar. We can do group counseling sessions. We actually have a great model for that when we go to colleges and we do screenings for Tay-Sachs and the other 18-plus disorders. We've had videos. We've had private little areas where people can ask questions, and it does work. We screened, I think, 167 people in 4 hours. So that's a lot of people.
And the other point to make is that, and some of the studies are set up, for instance, the Israeli follow-up study right now is set up so that if people have a family history, they actually are required to come back and meet with the genetic counselors. Yeah. And let me explain that a little bit more. One of the challenges with population screening is if you just kind of send the Ashkenazi Jewish panel off on people and you kind of get back and you tell them they're negative, if those individuals have a strong family history, that may not be sufficient testing at all. Remember, genetics is more complicated than that. There are other genetic hereditary cancer syndromes. We might have to go through the whole book and go word by word, not just those 3 pages, depending on the strength of the family history. Maybe only one branch of the family is Jewish, in which case those 3, testing for those 3 pages was not sufficient. So we do have to be careful with the fact that a negative is only meaningful in particular context. And also, if you don't have a strong family history and you test negative, you're still at risk for breast cancer, the same as in the general population in the United States, which is not insignificant. So these are just all sort of we have to make sure that people end not on oh, good, I can stop getting my mammograms, because that would be the wrong answer. And I'm not saying that's what people would think. We just don't know yet. No. Okay. I'll be quiet now. Sorry.
We're going to turn to questions soon, so just write down your questions if you have them. We're going to talk a little bit, few more minutes. So am I right, though, Eddie, in thinking that, from what you said, I don't want to extrapolate about your interpretation of Jewish law, but that there is nothing in Jewish law that says, you have to have a family background in order to get this test.
Jewish law would say that whatever the scientists of the time recommend, and I'm not punting on this one. It's really true. I mean, there is a principle in Jewish law, by the way, called I'm just translating into English, that a judge in any particular generation can only adjudicate an issue based on the information of his time. The problem is, as we see, and fortunately and unfortunately in the generation that we live in, we are amassing immense amounts of information, more so than any time in the period of history. The problem is we don't know how to digest most of that information. So we're in this continual chasm where we have the information, but we don't exactly yet know what to do with it. But at the same time, there are people in this audience, all of us included, who have to make real decisions. And you can't wait for 10 years hence for the information to become clarified. So you have to make the decisions based on the information that you have now. And Jewish law relies heavily on the science. And these are scientific studies that are done with thousands of people and that are replicated and extremely important. However, I just want to hasten to add, because we talked a little bit about timing for ovarian cancer, I'd be remiss if I didn't at least briefly address the impact of testing on the shidduch world, on courtship and marriage, and the tremendous burden it is on our children who carry this information with them, and how are they to address that with a potential spouse. So this is an extremely essential point moving forward in terms of testing, especially if we recommend community-wide testing. We have to be extremely cautious about when we recommend that testing, how we allow people to digest that information, to destigmatize people who are found to be positive for that testing so it doesn't preclude their ability to marry. We don't want, God forbid, to be an island of pariahs of people that are labeled with a genetic condition. So we have to move forward very cautiously, and these kinds of conversations are an essential role in developing a community-wide approach to these things.
Well, yeah. Well, what about that? I mean, that's a really. So I did a story on a young woman who tested positive for Huntington's disease, which has nothing to do with Ashkenazi Jewish descent, but it's a terrible disorder that.
He's also autosomal dominant.
Is autosomal dominant. She knew that her grandfather had it because he died of it. Her mother, the grandfather's daughter, did not want to be tested, as many people in the Huntington's community do not want to be tested, because it is if you have the gene, you get the disease kind of gene. And it's a terrible, it doesn't strike until about middle age, and so you can live many years without knowing, and sort of maybe you prefer not to know. But there's also a movement among this community of young people to know, and also to destigmatize the idea that, but dating is a big issue, or that comes up. So let's talk about that in terms of BRCA testing. So let's say you offer this to the whole population, young woman gets screened. When do they bring that up on the first date? I mean, what happens?
That's not.
Third date. I heard the third date from
In general, we like to say knowledge is power. But there are those patients who really don't want to have that knowledge. And for them, that knowledge is a burden. I would say that in general, most people do feel knowledge is power. But we do, when we counsel patients, we tell them that anytime you do a genetic test, you're not just testing you, you're actually doing that genetic test, and then depending on the inheritance, you're testing the family. So you have to think of the broader implications. And sometimes these patients don't want to know. So we had a mother who unfortunately had died of ovarian cancer, was BRCA positive, and this was right in the beginning, and she didn't want any of her daughters to know. And she put it in her will to tell them after they got married.
Wow.
And she put it in an envelope, and she just didn't want the family to have the stigma, and she felt such tremendous guilt about passing on this genetic mutation.
Did they test for it? How'd the daughters do?
Unfortunately, I haven't seen them, because they were at least 10 years ago, and they probably moved out of New York, who knows. But it's empowering. But yet it can be a burden to some. So that issue has to be worked out beforehand, and how do you feel about it?
So we generally do start screening with breast MRI at around age 25, just to give a sense. So until age 25, even in families where there's a known BRCA1 or 2 mutation, we don't have anything specific to offer family members in most cases. So 25 is usually when we offer testing to the women. And we sometimes get people in at 18, and we talk it through with them. And the occasional person really wants to know, even though they know we're not really going to do anything. And other people are tremendously relieved that at age 18, they don't need this information. So as always, it's a little different. Now, the people we tend to see are people with a family history. So the question becomes, if you've got a 25-year-old with no family history, when's the right time to test? So that gets back at that same issue. And it does get complicated. We have plenty of women between ages, 25 and 40 that we follow, and they're navigating, breast MRIs and pregnancies and, dating and marriage. And yeah, it's complicated. And there are support groups that are available for young women to help them through this. And obviously, clinics that help them, but we don't want to minimize the fact that it is a burden that at 25 you kind of feel like your body is working against you just as you're sort of kind of arriving in your sexuality and dating and marriage, and it can be a challenge. Although, as Susan said, for a lot of women who've seen cancer devastate their family, they do view this as extremely empowering information that they now can take charge of.
Do we know right now how many women who would be considered at risk for because of family history and Ashkenazi Jewish background actually do get tested? Like, how many people that should get tested?
I think it's relatively a smaller percentage. I think we'd like to think in the medical community that we are getting to everyone, but traditionally, family history is the last thing the doctor asks in the physical. Oh, what runs in your family? Okay, now you go change, get into your gown, and I'll do the exam. But we really need to know our family history. I'm just thinking of a patient who didn't think that she was at risk because her grandmother, she told me, had stomach cancer. This was very early in my practice. And her mother had bone cancer. But in fact, her grandmother had ovarian cancer because Jewish women really don't get stomach cancer that often. They get more likely to have ovarian cancer. And her mother had breast cancer that had spread to the bone. But everyone wanted to protect this young girl because they thought she shouldn't know that of the cancers that afflict her family.
Okay. The other thing is that so I get emails all the time from people at my institution, which is a pretty good institution, and the fellows will email about some family history, and the first question I always ask back, are they of Jewish descent? And I'm like, just tell me up front, because I will always ask you this question because it's so important for genetics. But it's not, if you guys go to some place with electronic medical record, now our electronic medical record says, have you traveled to Liberia recently? But it doesn't actually, during the cancer history, it doesn't say, are you of Jewish ancestry? And yet that question is really critical to any family history. So are these pieces, like, you need to know your family history, you have to ask about your family history. People didn't used to talk about it at all. People talk about it more now, but we will send people on little hunts. Go talk to your cousin and figure out exactly what your aunt had, and it's amazing what information they'll find. So that is quite important, and so I think that there's a lot of missed opportunities. These days, when young women come in with cancer, a lot of testing occurs, but there's a lot of people out there that had cancer before we were routinely doing genetic testing that they're just kind of missed. And if no one's following up on that, I think there's still a lot of people out there that still could get tested.
So even though their insurance would cover it, there are a lot of people that are not getting tested. And just on that question of you're not asked about your Jewish ancestry, is that because it's like an un-PC question? Like, is that because of the historical connotations of being asked?
Well, it is an interesting
Or is it just
thing.
an omission, or is it kind of
I think you have to be careful how to ask it. So we always say ancestry, and we say because it has relevance to cancer risk. So we try to frame it. But if you kind of ask it out of context, people can get a little bit miffed. And my favorite story, which I really shouldn't tell, but I will anyway, which is we had a German woman once, and we asked her if she was of Jewish ancestry, and she told us no, and she had the papers to prove it. And we were really, really hoping that she was going to have one of the Ashkenazi Jewish founder mutations, but she didn't. So yeah. Yeah.
Well, all right. I'm going to ask you. We're going to turn to questions because we promised questions, and I think it's time. Yes. So, but before we do that, does anybody want to make any last point? Do you have? There's a study going on. Do you want to talk a little bit about your plans for looking at this, or? No,
we can. I don't know if you want to wrap it up first, and then I can say that while everyone's. I think we've all, I can mention at the end, I think we've all reiterated how important family history really is, and the studies for the future will actually ascertain and or confirm what they found in the Israeli study. And we are, there are a lot of unresolved issues with BRCA testing. I think that you've kind of got the feeling about population screening today and what some of the issues are, and we do plan to study that at Albert Einstein College of Medicine.
Okay. Any last points before you can make your last points when they ask questions. Go ahead. Okay. All right. So do we have a microphone? Great. Okay. I'm going to start with some written questions, and you guys can get to the microphone. So should men in high-risk families be tested too? Should men be tested? Yes.
We'll just
Go
go
for it.
randomly in order. So yes, we haven't really discussed men, and we're sorry. So as you heard, if there's a mutation in the family, the men are at 50% risk as well. The risks to men aren't nearly as high as they are to women, but men are at increased risk too, for particularly with BRCA2 mutations. There's an increased risk of male breast cancer, of prostate cancer, of pancreatic cancer. That's true in both men and women, and a slight increased risk of melanoma. So there are increased risks to men, again, more BRCA2 than BRCA1. We don't have great guidelines for how to manage men. We're trying to come up with those as quickly as we can, but there are some guidelines out there.
Okay. I'll read another one, and then we can take one from the audience. If a family has a lot of breast cancer, but they test negative for BRCA mutations, does this mean that there is no hereditary cause of the cancer?
I'll take you back to figure 1, where we talked about the fact that 7 to 10% of breast cancer and ovarian cancer is hereditary, but really only 80% of that is attributable to BRCA1 and BRCA2. The other 20% is probably somewhere in the order of 50 genes, maybe even 100 genes, some of which we know of and some we don't. So there are now cancer panels for high-risk families who test negative for BRCA, and those are generally covered for high-risk families. And those can include anywhere, depending on your family history and what types of cancer, 5, 20, or more genes.
Okay.
And they're very recently, as in this year, commercial, but there are also research panels in major institutions.
So if you have your family history and you get tested, you test negative, you should ask your doctor for this panel.
You can talk about that at the initial counseling session, actually.
Okay.
It's really complicated and messy right now, and it's rapidly evolving. And still, even most of the time, if it's negative for BRCA1, it's still true that most of the time, even the panel will be negative. So your family history always trumps everything, even if genetic testing is negative.
The problem...
Because there are genes we don't know about.
Right. We don't know about. So the problem with any kind of genetic test now is that the answer can be yes, you have the mutation, no, you don't have the mutation, or you have a variant of uncertain significance. So that is the bane of the geneticist's existence. Why? Because every test you do has a 1 to 2% chance of this variant of uncertain significance. And if you test for 50 genes, you're going to have a 100% chance of having a variant. And we don't know what to do with those variants.
Okay.
Tough.
Yes.
Okay.
How much does the test cost? Okay. There's a microphone for you.
Okay, I'll do this one really quickly. 4,000 is the entire book, page by page, every word. 400 is the 3 pages, which are the common mutations in the Jewish population. So because we're going to only 3 specific places, testing is much, much cheaper. It doesn't matter if you have cancer or you don't have cancer. Cost of the test is the same. The labs are different, meaning there are a number of different labs that now offer testing, and the costs are slightly different one versus another. But insurance generally covers the cost of the test in most cases, not necessarily for population-based screening, but if you have a family history, they will.
So it's not okay if you're just of Ashkenazi Jewish descent, but if you have a family history, your insurance
I have to tell you that the
cheaper.
threshold to cover genetic testing in people of Jewish descent is extremely low. So the insurance companies cover a lot of it. I can't promise that they would cover every last bit of it, but I have to tell you, I can't remember the last time we had someone who was of Ashkenazi descent who didn't get covered. Medicare is a little more complicated. So Medicare, if you're not affected, that can be a little more complicated. But again, some companies offer the Ashkenazi Jewish founder mutation testing for as low as $250 or $300. So it's also not out of range of just getting the test without your insurance.
But under what circumstances would you want the $4,000 test? Let's say, I mean, if you test negative for the 3 founder mutations?
So I asked Mary Claire King this, and she said only one patient. So in general, if you're Jewish and you have a BRCA 1 or 2 mutation, you have one of the 3 founder mutations. I personally have never seen an Ashkenazi Jew who had a mutation who has not had one of those 3.
It happens, but
It's rare.
It's not common. So usually what we do is say, we do the 3 common ones first because it's cheaper. And then we look at the personal and family history and decide whether to look at the whole book. And that just gets into issues of, again, that in addition to cost, there are more variants of unknown significance. So we sort of take that into account. But it definitely, the way we often do it in our clinic is if you met criteria to get covered for BRCA 1 and 2 testing, if you weren't Jewish, then we'll do the whole book. But if the only reason you're testing you is because you have a higher risk because you're Jewish, then we test for the 3. But we always test for the 3 first because it's cheaper.
And there are some insurance companies, if you're Ashkenazi Jewish and you test negative for the 3, depending on your family history, will not cover for the 4,000. I just want to mention the Medicare because this is important because Medicare is generally patients who are 65 or older. And what Medicare is banking on is if you're 65 or older and you have not gotten cancer yet, it's unlikely for you to have a BRCA mutation. That's not necessarily true all the time, but that's why they're not covering it for unaffected patients.
Okay. Another question, yep.
So specific to what you were saying, my mother has a carrier of mutation 2 that's not one of the 3 basic carriers, and I, as a 35-year-old male, this past summer had been diagnosed with breast cancer. And when they tested me for the 3 when I did the BRCA gene testing after the fact. They did the testing for the 3 basic mutations and also the same mutation that my mother had, which I was a carrier, of the additional mutation. So it certainly is possible and certainly to be passed
And
down
again,
as well.
a man with breast cancer is a red flag whether you're Jewish or not. So like
So
you
you
throw
get-
the book at you. So one
But
way
had
or
I
the
been
other.
tested for just the 3,
Correct.
not knowing my
Right.
mother's history, I would have been tested as negative.
Right,
I think
but
being a
because of your
male-
personal history,
Yeah, right.
they
You would
should
have
have
done the whole
then
thing.
done the whole book anyway. So this is why genetic counseling is important because sometimes it's complicated. So
And the other issue is that
she has
we don't know that we're 100% Jewish, everyone in this room. You know, we don't know that for sure, right?
As my wife and I look to start having a family, we are looking into PGD. But I've also heard that from my oncologists and from different people that they're close or definitely making steps towards finding out what causes the BRCA gene to the mutation to turn healthy breast tissue into non-healthy breast tissue. And just anything on that or advances that are being made towards that now.
Yeah, so I mean, we're lucky because thanks to generous donors, Minnie and John and Sharon Lynn, the Bassler Research Center has put a lot of money into trying to do basic science investigations of those issues. I wish I could promise you that we'll have it all figured out for your child. We certainly hope that we have a lot better options than we do right now. And you're right, we're trying to look at things like preventative vaccines and trying to look at the machinery of how things are working so that you can, try to change that initial, what the initial thing that goes wrong. But right now, we don't have that in our hands right now. Right now, today, if your goal is to try to prevent transmission of the gene mutation, your best bet is PGD. But of course, we're actively working on this so that people have other options.
And part of the long-term studies include looking at, we do know some of the environmental factors, that's obvious, but there have to be modifier genes because why is it in some families everyone gets cancer who has a BRCA mutation and in some families, there's only one person. So what are the other people inherit who have a BRCA mutation who are not getting cancer? And it may be a combination of genes. We don't know that yet.
I'm going to take another one from the audience. Go ahead.
Actually. And I'm somewhat, back to the population screening issue, I'm somewhat skeptical. I just don't know, how can you really ensure that people are having kind of true informed consent and really know about the risks, benefits, and limitations of testing So that's one issue. And then the second issue is the false sense of security if you test negative. I mean, this gentleman over here was talking about not having one of the 3 Ashkenazi Jewish mutations, and it's entirely possible, just based on family history, that there could be some other gene or some other mutation. So that I feel like are some of my concerns. I don't know what you guys have to say about that.
Do you want to address?
I think
one of
it's
the
really well
citizens?
said, and I think it really has to do with the fact that, it's really implementation of how you do this. It's really the nuts and bolts of how you offer this to people in a way that you're getting an adequate family history so that you're making sure that testing for just the 3 Ashkenazi Jewish founder mutation makes sense. We haven't even talked about there's hereditary colon cancer syndrome. What if you have that, but you've been tested for this, which has no relevance at all? So I think that there really are challenges to doing this in the real world because, Susan and I do this all day long, but if we tried to see every Jewish person out there to do this, the system's overwhelmed. So we have to figure out a new approach, a new strategy if we're going to do this, and we have to study it. We can't just start doing it. I think that we have the potential of doing more harm than good without doing it the right way. That's my opinion. So.
Okay. We have a lot of questions, so I'm gonna limit it to that. I am 65 years old. Why would finding out my BRCA status at my age be helpful?
If you're a woman and you still have ovaries, you would want them taken out because ovarian cancer risk is still quite high, and it has relevance to other family members.
You would want to know for your children and for your siblings and for their children.
Okay. Can you address GINA, which is the Genetic Information Non-Discrimination Act, which, yes, I think we really should address GINA. So there was this law passed in, I think, 2008 that said you're not allowed to be discriminated against based on your genetic information by your insurance company or your employer, right? Is that, how is that working out?
This is discussed in every genetic counseling session, and that's why it's important. Could it be discussed via a webinar? Yes, it could. But GINA protects you so you do not lose your medical insurance, but it does not protect you for life insurance or long-term care. So we have many patients after getting counseling who go out and get long-term care insurance and or life insurance and then come back and get tested.
Uh-huh. And has that law been tested? I mean, in terms of has anybody challenged the?
Well, the irony is so first of all, George Bush passed it, which is interesting. And when it was going through forever. And they kept coming to, large centers and saying, bring us your patients who have been discriminated against. And we didn't have anyone to bring them because it actually turns out that if you have a breast cancer diagnosis, people would have a hard time getting life insurance, everything. And they would be like, is this my BRCA1 mutation? But you're like, well, you have breast cancer, and that is always part of what's been used in life insurance and health insurance before the Affordable Care Act, right? So it always was a little bit complicated, and we never really, so it's hard to get at, actually, what the impact is, but we haven't seen it. We actually really haven't seen it in practice. I don't know if you have.
There are some life insurances that ask, have you or any of your family members have genetic testing? And there are some that aren't. And also, it also depends who at the insurance company is reviewing it.
Right.
And how savvy they are about this.
Okay. Am I missing anyone? I'll take one from.
One second.
Can you just wait for the microphone?
Yes. I am a facilitator for a group of stage 4 women with breast cancer for many, many years, couple of decades actually. And so anecdotally, I know that not all breast cancers are equal. And also as a survivor myself, that some very early stage cancers prove to be far more aggressive. And some people are found with somewhat later stage cancers and they survive a long time, 20, 30 years. And so is there some way that the genetic testing looks at the differences between more aggressive cancers and less aggressive?
It's a great point. Right now, we've been talking a lot about the genes that you're born with. And we think that what you're describing has more to do with the genes in the cancer, sort of the specific genes in the cancer that sort of develop as the cancer develops. We don't really know of anything hereditary that impacts survival, if that makes sense. Those probably have to do with more the genes in the tumor, those specific genes. And people are doing a lot of work on that. We don't have it all figured out yet. And you're right, there's a huge variability. There's enormous range in how long people live, even with stage 4 breast cancer.
All right, I'm going to take a card. For each panelist, if you had a 35-year-old daughter who was done having children and positive for BRCA2, what preventative measures would you recommend?
Just very quickly, BRCA1 and BRCA2 are different because the risks of ovarian cancer are higher for BRCA1 and they're somewhat earlier. So for BRCA1, we tend to err on the side of earlier oophorectomy than for BRCA2. So for BRCA2 mutation carrier, I'm actually okay with waiting till like 40, 45 with informed consent about oophorectomy. And I really view mastectomy versus breast screening as a choice. And these are long discussions, and people generally have a very strong opinion about what they want to do, and I think that's all right. So yes, they will eventually need oophorectomy. There's also, we don't have time to discuss today, but just removal of the tubes only as a temporizing measure, which is there are no good data for, and then a long discussion. It definitely needs breast MRI and a discussion about mastectomy.
All right. Do anybody want to? All right. Will you? You asked for.
We have a lot of more
yes,
questions,
we do.
right?
Yes. All right. Let's see. I want to get tested. I have a small family and not much history because of the Holocaust. I don't want to spend time on family history. Not sure it's valuable. Where do I go to get tested, and what do I need to know?
You go to Susan.
That is a question.
Yeah.
Where do people go? Okay.
So I'm not going to lie. There are medical doctors and gynecologists who are just sending the kit from their office. None of us here really believe in that. We really do believe in the pre-test counseling because of all the reasons that we've stated. And we can all tell you disaster stories of people who've come to my office with, my doctor did this test, I don't know what this means. So I do believe in the pre-test counseling. I think you should see a genetic counselor, and most major medical centers have genetic counselors. If you're in New York, you can Google New York State genetic counselors, and they'll all come up, and so you can find one that's nearby.
But to emphasize, I mean, we have people come into our clinic who are Jewish without a strong family history or with virtually none. We will test people who are of Jewish ancestry. So, you know, that's the difference between people coming in who want to get tested versus population-based screening. Those are actually different things. I know it sounds weird. Population-based screening means you go and offer it to everybody, and you think it's important that everybody has it, which is different than saying, hey, you can get this test, come get it. And those are two different things.
Okay.
And our goal with our program is actually educating people, because if you are a proponent of population-based screening and you are educating the public, it is very likely that you are going to find families that are of high risk who actually thought that they were of low risk.
Okay. We have 3 minutes, so I'm going to take, is there anyone else in the audience? I'll take one more from the audience and one more card.
Do you study, oh, sure, I'm sorry. Do you study intermarriage, not intermarriage, of different religion, intermarriage within the Jewish community? Are there studies going on with people who live in small areas that are marrying each other in small communities, or just marry their friends, as opposed to the greater New York community? In other words, there's high-risk breast cancer on Long Island and in Westchester. So do you study, is anybody studying groups within groups?
I'm not sure exactly your question, so I'll take a stab at it. We always, when we do genetic counseling, we always try to find out if we have a term for consanguinity, which is that people who are related to each other closely have married and have children. But within, you know, but there's actually, that's generally for recessive diseases where you need one bad copy from each parent. And so in the Ashkenazi population, you know, it's just enough. That's enough. You don't have to be, you know, first cousins or anything like that. It's just the Ashkenazi population. I'm not sure I'm answering your question the right way.
But the risk in the non-Ashkenazi Jewish the risk in the non-Ashkenazi population is about 1 in 345. That's the risk of having a mutation. So, and the risk in the Ashkenazi Jewish population is 1 in 40. Some studies say up to 1 in 100.
Okay.
You're asking more about environmental risks, and those are being tested for Long Island and
I wasn't so much thinking of environmental. I was thinking people who are physically close to each other, families knowing families and marrying for generations. I mean, it's almost like as if you asked what diseases are passed in certain cultures or groups. So I guess I'm just passing it on to the local question.
All right. I think we're moving on to the last question, which is going to be for Eddie. It's a question about what would Jewish law advise. This person was tested positive, had a prophylactic oophorectomy, some other details. But the person would like to share their story because they feel like it could be life-saving for others, but she feels like being public about it would be a violation of her son's privacy, since he has a 50% chance of having the mutation. So I balance the definite wrong to my family versus an unknown help to an unknown person. I have balanced this by telling my story anonymously. What would Jewish law advise?
Yeah, excellent question.
Back and relax on this one.
Yeah, a wonderful question. So first of all, it's wonderful that you shared the story anonymously. Is a tremendous benefit, and Jewish law has a lot to say about confidentiality and sensitivity to information. So your concern about publicly sharing something which a family member may not be interested in sharing is a very valid one. Because it's not necessarily your information exclusively to share. And by the way, even in terms of what potential spouses should share with each other as it impacts on BRCA or Tay-Sachs or things like that, there are very detailed legal discussions about which diseases have required disclosure and which are not required disclosure. So to balance that with your desire to help, I mean, in this day and age today, with the web, with the internet, you can publish these stories anonymously and even change some of the facts enough so that it's not identifiable, and still have a tremendous impact, broad impact, without divulging any details or compromising any confidentiality.
All right, Jewish law has spoken. And we are done. So thank you very much for your questions. This is really, thank you, panelists. You were great. And we continue outside with, I think we'll be around.